but we'll get started. And so welcome. My name is Emily Weiler. For those of you that don't know me, I'm the program coordinator for the Montana Public Health Training Center. We're located here at the University of Montana, as we were just saying, in a very unsnowy Missoula Valley. And we have a wonderful training for you today. So in terms of housekeeping, just know you're muted upon entry. So if you're asked to speak, make sure you unmute yourself. If you get kicked out for any reason, like on accident, if you lose connection or something, it doesn't just disrupt anything. So just log back in and I'll let you back into the room. I'll be managing the chat box. So if you have questions for me or Kimber, just go ahead and I'll be keeping an eye on it. Same if you have any technical difficulties. And otherwise, I think we're ready to go. So I'm going to stop sharing my screen. And I'm going to turn this over to the wonderful Kimber McKay, to get us started today. So go ahead.
Thanks, Emily. And hi, everybody, and welcome to Social Determinants of Health. So hope everybody can see my screen here. I think I might need to maximize this thing here. Emily, how's this look to you?
Perfect.
Okay, great. So as Emily said, my name's Kimber McKay, and I am a faculty member here at UM in public health. And Emily, I
forgot about this. Talk about this. So folks, this is exciting for us. We can finally offer some nursing credits for our trainings. And so this is our first one where that is applicable. And this time around, it's free. So if you need nursing credits, if this applies to you, we just need to be in touch so I can make sure I can get you a certificate of completion. So this is just the disclosure. Stay through the whole thing, fill out the evaluation at the end, and then I can send you a certificate and you can get those credit hours.
Great, thanks, Emily. So I would ask everybody if you wouldn't mind to please introduce yourself using the chat box. So you could say your name and where you're from, where you're located and where you are working, maybe a job title or just a brief explanation of what your public health related main duties are at work. Just that gives us a sense of community and who's who on the webinar this morning. What we're going to do today is spend the next 4 odd hours or so working through 4 different sessions, which I've put together. And in each session, there are a couple of opportunities for me to get feedback from you using the poll function in this platform. And Emily has those set up, and that will just appear on your screen, and then you can click in the places you need to click. And I think that will be pretty self-explanatory. And then we also have, related to your responses to those polls, we also have a couple of breakout room opportunities, actually 3, where we're going to be putting you into small groups, and you're going to be talking about the way that you responded to those polls so that you can develop a sense of a shared public health practice community with other people from around the state or other locations. Not everybody is from Montana in our training center webinars, but also gives you an opportunity to talk about what the specifics are that you're faced with on the ground in your own community and your public health practice, having to do with specific groups of people and how they may face different challenges that are framed by social determinants of health model. And so later on in the 4 hours together, you guys are going to be in these little breakout rooms with 5 or maybe 6 of your colleagues here on the call, on the webinar. And then we're going to ask that after those small group discussions that we rejoin the larger group, and that one person from each of those breakout rooms will be in charge of sort of reporting to the rest of the participants of what all came out of the conversation that you guys had in the breakout room. So one of the things that we're going to have to ask you to do is elect in each of those breakout rooms, which will be the same group of people in all 3 of them, who's going to be the spokesperson for the group. So we'll come to that later. And I see a couple more people coming into the waiting room, so I'm clicking. I'm sure you are too. And somehow I can, I don't see the chat box myself. Oh, here it is. Oh, I just need to move it over here and put it on the other monitor. So it's good to see a good geographic representation around the state, some out-of-staters as well. This is excellent. I think this is going to lend to a really rich conversation. Thank you for putting the details in there. Like I was saying, I'm a professor here at the U in Missoula, which is in the western part of the state, for those of you who are not from Montana. And my background and training initially was in medical anthropology and coming at health and health-seeking behavior cross-culturally, and to understand how people from and using different perspectives on life, on health, and how to seek better health really differs from one group to another. And the picture here is where I did my dissertation research in northwestern Nepal in the Himalayas. And there people have a very different way of thinking about health than we do in sort of mainstream American culture, where they don't ascribe to a germ theory of disease. They think that diseases are caused by other forces in the environment. Some of those forces can be social or can be supernatural, or they can have to do with the way that you're square or not square with your ancestors and so forth. And so for me, living in this community was a eye-opener for helping the development and global health practitioners understand how to design and execute health-related programming in this group of people, where the programmers and the implementers had a very allopathic or Western sort of mainstream understanding of the germ theory of disease and how to avoid getting sick and how to get better when you are sick, how to help them understand how differently these people thought about those kinds of things. And that really led very naturally into what we now refer to as the social determinants of health model or framework, which is now very commonly used across all across the United States in both, I would say, from the federal to the state to the local level as well. And very interested in learning more from you at the outset here about how many of you are already using a social determinants of health framework in your work. So we're going to put up a poll in just a second having to do with that. I've also worked extensively in East Africa with specifically with newborn child and to a lesser degree maternal health initiatives. And so out of all of the kinds of health initiatives that are out there, probably my main expertise is in maternal newborn child health. This youngster is at a well child clinic in a mobile healthcare outreach program where people do not have the means to come into the hospital and or to the health clinic to get their vaccinations and things like that. And so the mobile delivery of services is very common in that setting. So in this first session here, what we're going to be focusing on basically is just a background and key concepts to the social determinants of health model. And before we begin, I was going to just ask Emily to put up that first poll for us. So having to do with whether or not you're currently using a social determinants of health framework in your work or your organization. So I'm just curious how many people are familiar already. Good. Okay, so I can see we're pretty evenly split between people who don't currently use or are unsure if they do. You might be using it and not realize it, because the language is not there. And so, okay, that's very good. Thank you so much for sharing that. And that's good to know moving forward. Okay, so I guess I'll stop that. Okay, so background and key concepts. There are 5 core areas in the social determinants of health approach, and those are listed on the slide here and then broken out into sort of sub areas. So the 5 main areas are economic stability, education, social and community context, health and healthcare, and the neighborhood and built environment. And so under each of those, you can see some of the specific considerations. So for instance, in economic stability, people look at employment, food insecurity, housing instability, and poverty rates. Under education, you can see this goes from early childhood education through high school and then language and literacy programs. In terms of social and community context, we have things like civic participation, like access to healthcare generally, specifically to primary care, and then also health literacy. And then last, we have neighborhood and built environment, which is, to do with what are the conditions in which people live, like whether we're talking about the housing that they live in, indoor air quality, presence or absence of lead paint, or the built environment around them. Things like, do they have access to sidewalks, or do they live in a food desert, and things like that. Those all would come under neighborhood and built environment. The way that we organize ourselves in the public health sort of industry these days, it falls under a couple of different rubrics, and these I hope are probably familiar to many folks on the call, but I'm also aware that across our state, Montana, there are a lot of people working in health departments around our state who don't have public health training per se, who have come into the role from a clinical background or other, professional paths that haven't really included formal training in public health. And so I like to start out these webinars talking to you from, whatever corner of the state where you reside, with a little bit of a refresher on what we mean by public health. I used to teach in this face-to-face back in the day, public health training, or the Public Health Summer Institute. And some of the folks that I talked to or had in my classes there said that they didn't actually know like what formally public health was, or how to talk to our county commissioners about what public health is and what its practitioners actually do. And so I think it's always a good starting place. So Public Health 3.0 is one of the kind of overarching rubrics or ways of understanding what public practitioners are engaged in. And we see it having sort of 3 phases, where that the start in late 1800s really of the formal organization of public health as a field was a period during which there was a lot of growth of knowledge and tools, both to medicine and ideas about public health. And those of you who are familiar with public health history will know about the famous Broad Street Pump study that was initiated by John Snow, where the cholera outbreak was isolated to a particular water source in London. And so this really is considered to be one of the first or seminal research projects and then public health initiatives certainly in an urban setting. And so during that time, as people will know, people living in those neighborhoods around the Broad Street Pump and other places in the city and across that country had uneven access to care and public health. And that's true actually in some corners of the world today still, and also even in the United States, in more rural or frontier communities, we certainly do see this reality persisting. Public Health 2.0 was organized in, really in the latter half of the last century, where we saw the systematic development of public health government agency capacity in our country. And during that time, the focus was limited to quite traditional public health agency programs and that kind of a centralized focus. In Public Health 3.0 era, we see a shift where the groundwork was already being laid more than a decade ago toward what we now recognize and call as the social determinants of health model, where we are seeing, starting in that time, a heavy emphasis on engaging multiple sectors and community partners to generate a collective impact, and also trying different initiatives that were focused on trying to improve the social determinants of health, although that language wasn't used initially. We also see that our work as public health practitioners is organized under initiatives which we refer to as Healthy People, and there have been, I think, 3 more decades now of Healthy People. We just segued out of the Healthy People 2020 era, and we're now into Healthy People 2030, which was announced last fall by the outgoing Surgeon General. And in Healthy People 2020, which the front page of their web is featured here on the slide, was one of the first times that we saw the social determinants of health being specifically named as a focus area with programs and evidence base listed under it. So you can see that on this slide, in red font, new, social determinants of health. And so toward the second half of Healthy People 2020, we started to see a stronger and stronger evidence base emerging for what are the programs that work and what are their features that are specifically effective and in what settings. And the thing that I love about Healthy People 2020's website is that you can see on these tabs up here, other than the overview, which is the one that I have open here, you have objectives, interventions and resources, and then national snapshots. And so on your own time, if you're interested, you can go to this website and click through. And there are tons of really useful resources here, from toolkits to metrics and objectives to be met, and data from different locations in the country. And I find this extremely useful for organizing my thinking, but also in helping people that I work with. I also teach one of these webinars on program planning and evaluation. And so these kinds of tools are extremely useful for people who are starting to think about developing a program and using metrics that are and so forth. Like I said before, the Healthy People 2030 overarching sort of narrative or rubric was recently announced, and so that website is now live. I don't actually like that website as much as Healthy People 2020. I've spent quite a bit of time on it, and not as resource rich in my estimation as Healthy People 2020. So I would encourage you to look at it and see what all is there. But I think you're going to find Healthy People 2020 a little more useful now, until Healthy People 2030 is a little bit more up and running and more populated with studies and things like that. Studies and tools and metrics and all that sort of thing. What it does do, which I will show you later on in my presentation, is it does show how the metrics change from 2020 to 2030. So there is some specificity there, which could be useful, but I still like Healthy People 2020 better, especially for people who are a little bit fresher to the framework and how to use it. But anyway, I do like this one schematic, which has to do with how can I use Healthy People 2030 in my work. And so you can see the the icons at the top that pertain to how do you identify needs and priority populations where you are working, how do you set targets, how do you find inspiration, practical tools to bring your ideas to fruition, and then how do you monitor progress locally and measure it against national benchmarks. So I think that's a useful way of thinking about the task that faces us as public health practitioners or people who are trying to get organized on developing or executing programs. So I just wanted to make sure to orient you to those 2 pages. Specific issues in rural contexts are going to be familiar to people here who work in rural and frontier parts of our state. First of all, we know that in rural places, there's a disproportionate burden of chronic disease relative to the general public, especially on the coast and in more urban places. Obviously, we have restricted access to quality health care, insufficient or lack of health insurance coverage, isolation geographically speaking, and lack of transportation to get to care, and poor infrastructure. We also see in rural places that we have lower educational attainment and lower health literacy. We have higher rates of poverty and unemployment, a smaller healthcare workforce and lack of specialty care, limited availability of bilingual providers and interpreter services, and then oftentimes some quite different cultural or social differences, stigma and norms. Here in our state of Montana, we don't have as much social and cultural complexity as in other states in this country, but we have an increasing level of social and cultural complexity as more people move to Montana from other states. And also we always have, of course, some very significant differences in the way that people think about health and health-seeking behavior between reservation populations and non-reservation populations. And it's important to recognize that those differences exist and that they very significantly affect behavior. And so when we think about what the mission of public health is, I like these 2 definitions the best, which I pulled together here. From the Institute of Medicine, to fulfill society's interest in assuring conditions in which people can be healthy. And from the WHO, public health aims to provide maximum benefit for the largest number of people. Some of the key terms that I'll be using when I'm talking to you today are listed on this slide here and differentiate between clinical care, which I think is probably familiar to a lot of people here on this call. But in addition to that, I wanted to define determinant. I talk a lot about determinants in here, and that's to do with factors contributing to the generation of a trait or health outcome. We are unfortunately all extremely familiar by now with what defines epidemics or outbreaks with COVID going on, and health outcomes I'll be talking about as well. And those are the results of medical conditions that directly affect the length or quality of a person's life. So just to have that laid out from the get-go here. So public health has a long history of interest in both the sanitary and environmental conditions in which people live. And this goes back to the Greeks and Romans and carries forward into just before the era when John Snow did his work on the Broad Street prompt into different kinds of policies and legal frameworks that really underpin a lot of the environmental health considerations that we have as a public health community. And so this history is a deep and rich one for sure. With respect to pandemics, the same, from influenza to polio to HIV and today into the COVID era. We have a long and rich history of working with people who are up against epidemic or pandemic or outbreak situations. And there are, in fact, a lot of social and behavioral science findings and clues that help us as public health practitioners communicate with people and work with people to understand the complexity of the disease and the disease response that we're facing or trying to enact. And unfortunately, today, our ability to do so, to use those social and behavioral science findings and cues is a little bit, it is made a little bit more difficult by the social environment, particularly in this country that has, some political and economic and cultural underpinnings that relate to the way we consume news and media, et cetera. So we're definitely in a new era here. And I see that the social and behavioral science is sort of still struggling to keep up. But it's an important point for us to bear in mind, because those social and behavioral science findings and the cues that we use in public health messaging, et cetera, have a lot to do with the social determinants of health model. We also know that public health is essentially a preventative way of thinking about health, and it's often enacted through policy, through the policy environment that's put into place. And that also has a long and rich and varied history going very far back into history. I have the book of Leviticus here, which is considered to be the world's first written health code, and other policy or legal frameworks are referenced here that help us think about the way that the policy environment actually has its bearing on health and health outcomes and interacts in important ways, which you'll see throughout my remarks today. An important effect on the way that we think about the social determinants of health and how we can shape those or massage those social determinants in order to improve health outcomes. So just sort of finishing up here, the 10 essential services of public health for those who haven't had formal training in public health are enumerated here, from monitoring to diagnosing and investigating. We inform, educate, and empower people of all kinds, consumers, private individuals and citizens, to clinicians themselves, to inform, educate, and empower, to mobilize community partnerships, help policymakers develop policies, enforce laws, which is now in our being discussed in our state legislature, the extent to which public health practitioners can enforce laws. So that's an interesting development and very current here in our current legislative session. We also work to link to or provide care to our fellow citizens, assure a competent workforce, and we do evaluation of public health programming and, of course, research. When you think about the sort of buckets that public health work can be put into, we typically see a distinction being made between assessment, policy development, and assurance, where assessment is where we're systematically collecting, analyzing, and making available information on healthy communities, where policy is promoting the use of scientific knowledge in policy and decision making, and where assurance has to do with ensuring the provision of services to those in need. So a lot of public health practitioners find themselves in the position of simply advocating for their fellow citizens and people in their communities so that they can access the care that they need and that it's provided to them. When you think about the way that this is distributed, these three kind of buckets are distributed across assessment, policy, and assurance are distributed across levels of government. We can see that at the federal, state, and local level, obviously there are different levels of focus or units of analysis or units that we're working to affect change upon. And so these examples here relate to tobacco cessation and help us see where activity relating to helping people either not engage in or stop smoking would be distributed from the local to the state to the federal level, and how those would be separated out into assessment, policy development, and assurance. So the social determinants of health model is is used at all three levels, local, state, and federal. And so in the examples and the evidence base that I'll be presenting to you in the next few hours, you'll see that they fall into these sort of categories. So I'll come back to that later in my remarks. All right, so the health determinants. So getting more specifically into the model after sort of laying that groundwork. So when we look at health determinants, we understand obviously that there is a very strong role played by genes and biology, and that's sort of the underpinning or the framework or the foundation that some other things are layered on top of. And I think that a lot of people think that genes and biology are dominant, that the bulk of your health outcomes in life, any given individual, rest very solidly and dominantly on genes and biology. And that what rests upon that are health behaviors and then social or societal characteristics of the community that people live in, and then the way that they are or can access health services or medical care. The social determinants of health model itself rests upon some analysis, a body of analyses that has been done that establishes the relative importance of each of these four things on health outcomes. So this is a very kind of simplistic way of looking at that, and helps us begin to understand, I think, better that the relative roles of each of these things is not what you might think initially, and that the findings of these sort of multiple regression analyses and other ways of analyzing health outcomes tell us is that genes and biology actually play a relatively minor role, and are layered instead upon a foundation of social and societal characteristics, or the total ecology that people live in, and that there are also health behaviors and medical care that are playing a more dominant role in health outcomes in genes biology. So we talk about the health impact pyramid as a way of understanding the role of individuals and the role of public health impact or public health activity and the impact that it can have. When I say public health activity here, I mean the impact of public health initiatives. And so here we have socioeconomic factors being at the base of the pyramid. They underlay the ability of individuals to make healthy decisions and the extent to which they're making those healthy decisions by default. On top of that is preventive medicine, followed next by medical care, and last, counseling and education. And then when we add on top of that, again, continuing with the tobacco cessation model as one way of thinking about this pyramid, we can see that at the base with socioeconomic factors, you would see in terms of public health initiatives, you would see programs that are aimed at poverty reduction and education. Next, we have examples, actually, sorry, these examples aren't all smoking or tobacco cessation, some of them are. But we, at the next level, making healthy decisions by default, you have things like seatbelt laws, which provide a legal framework, obviously, for changing and shaping behavior, which hopefully those behaviors become behaviors by default, but not always, and have to be enforced. Next level, preventive medicine. We have activities like vaccinations and cholesterol screening falling at that level. Medical care is treatment, and above, counseling and education having to do with like initiatives like warning levels or campaigns to promote quitting. So this way of thinking about the foundational base and filtering up to more refined or defined healthcare or health promoting activities is a good way of starting us thinking about how the social determinants interweave with the policy environment, the legal framework environment, and then the activities of public health practitioners or clinicians. When you received the program today, you would have seen at the end of it this model or this schematic that's pictured at the left. And this is kind of the iconic social determinants of health schematic that you'll see across most of the literature and certainly every presentation like this on the social determinants. And it brings us back to that pie chart way of thinking about health and health outcomes and helps us understand the relative weight of all of the things that are in a person's social, economic, legal, policy, environment, and so forth, their neighborhood and built environment and those other things I talked about at the beginning, and how those all come together to affect health outcomes. So it's understood that that socioeconomic factors and health behaviors taken together, combined, exert the heaviest influence on health outcomes. So up to 70%, it's thought, from modeling that's been done. So socioeconomic factors, including education, job status, family and social support, income and community safety, and then health behaviors such as tobacco use, diet and exercise, alcohol use, and sexual activity. And those also, when we think about those kinds of behaviors, we also always see language being used to indicate whether whether healthy behaviors are used by default or not. In addition to that, we have the built environment, the physical environment, those attributes that I talked about earlier, having to do with the quality of housing and the environment that people live in around the housing that they live in. And then last is healthcare. So access to care, quality of care, and from my previous slide, also health literacy. So I think that we all know, as people who work in public health and are thinking about public health all the time and interacting with citizens in our community, that health literacy is probably more important now than ever. And it's a little bit more complicated in this day and age to talk about health literacy because of the appearance of studies or false studies on social media and in the media, the conventional media, traditional media, that confirm people's biases one way or the other. And so one of the things that we see in public health work these days, certainly the way that we're educating our students here in the School of Public Health at the University of Montana, is some initiatives working on combating disinformation and helping students understand the difference between good information and false information or disinformation, and it has become considerably more complex in recent years. So when we think more, drill down more into the social determinants, we typically see these 8 areas repeatedly coming up: housing, food, education, transportation, and then violence, social support, employment, and health behaviors. And in some of the studies that I'm going to be talking about a little bit later today, you'll see very specific and concrete examples of initiatives that were started by different public health practitioners, either at the state level or local level, health departments, where various of these pieces are woven together to understand health seeking or health modifying behaviors and what they have to do with, for instance, the nexus of some of these different factors together. There is, for instance, a radon study that I'm going to be talking about with you that brings together housing on the one hand and education on the other. And so you'll see concrete examples a little bit later. So this is just another schematic that drills down a little bit more into some of the other factors that I haven't mentioned so far that typically fall under these the main buckets of the social determinants. And some of the things that I haven't talked about yet are the influence of, say, for instance, debt or medical bills or economic support that's beyond a person's income, say assistance that they get from other community members or community organizations and the like. Under neighborhood and physical environment, I haven't so far referred to the existence and usage of playgrounds and the walkability of people's neighborhoods. But what we see increasingly in, say, for instance, initiatives focused on obesity is a social determinants of health framework being employed to help people understand that obesity programming typically is very much buoyed or supported by a social determinants approach favoring neighborhood initiatives that build sidewalk or green belts or playgrounds that people are accessing with their children, and establishing those healthy physical activity behaviors by default from an early age. Under education, I would imagine that a lot of folks on this webinar are struggling to knit together a focus on education or education, formal education through the school system, programming with what they do in their local or county health department. And I think that's a challenge that a lot of people have across our sort of industry. But I'm going to give you some examples later, which I hope will show you how other people working in public health have worked together with stakeholders in the education community to affect change in really positive ways. I've talked about food deserts here, where people simply cannot access without a huge amount of effort healthy food options because the local stores that they have available to them are they don't carry healthy foods, or most of the foods that they carry or sell are packaged foods, and so on and so forth. And so those problems or challenges are kind of encapsulated here in access to healthy options. In community and social contexts, I'll be talking about some studies that relate to the existence or not of social or of cultural and community support systems for specific groups of people, like for instance, migrant laborers or relatively new migrants to this country, which have a very strong effect on their health outcomes. So I'll come to that in a bit. And then healthcare systems, I think, is a little bit probably more familiar to most people on this webinar. And I've already talked here about health literacy and providing people with the translation services and cultural competency services that allow people to kind of basically translate between their own community or cultures thinking about health and health-seeking behavior and what's being promoted formally through the public health system here in our country. Okay, so I'm going to pause here and we'll go to our first poll, and that question is on the screen. So what would you expect your community's most powerful social determinants of health to be? So talking about where you're living and working right now. Of these options that I've talked about so far, where do you see the biggest challenges? So economic stability and is the leader on the leaderboard here, but then social and community context and neighborhood and built environment came in evenly. Interesting. I'm going to set this aside for the moment, and we'll be putting you now into our first breakout room. So in your group, please introduce yourselves to one another and elect a spokesperson. And if you could please discuss with one another what your poll choices were and why you chose them. I'm very interested to hear that. I'm also interested to hear some feedback and discussion having to do with the way that you're already using a social determinants of health approach in your work. And for those of you who have any interest in it, I'm especially keen, as somebody who teaches students who are going on to use either their bachelor's degree in public health or their MPH in public health practice, going back to yourself and your training, like what about this do you think would be useful for you to have thought about or learned about as a student? So feedback on that would be also very instructive for me, and I think for your group members. So we're going to put you in your groups, and
so Kimber, we have 5 groups of 5 or 6 people.
Perfect. That sounds good. And also don't forget to elect your spokesperson. All right, so Emily will put you into your groups. And it's a little bit hard to tell if folks are back because most cameras are off, but if you're back, if you could turn your camera back on or just give us a wave using the wave symbol, and we know that you're here with us.
We're here.
Are you here? Are you drinking coffee in the kitchen?
All right.
Excellent.
Okay, so
so let me share my screen here again. Okay, so could we hear back from our groups? And Emily, I think you might be able to give us a little bit of help in naming groups or somehow organizing who speaks when.
let's do it this way. So room 1, if anyone knows you were in that room, this is the room with Annie, Megan, Olivia, and the 2 Sarahs. So if anyone in that group.
Yes, that was us. My name is Sarah LaRue, representing Colorado Community Health Network. So we talked about some of the difference in language between communities most powerful and I think most important or most significant, and just how important really the built environment is around people. We have a couple, someone from an urban planning background, a couple of public health backgrounds. And so we really talked about I think some of us are new to the public health sphere. And so talking about learning about how public health's role is so much bringing context into health and kind of bridging some of the siloing that can happen in medical trainings of all kinds, and bringing in just how impactful people's lived environment and built environment is in just in their participation in their own health. And then we talked about I mean, even things like the term non-compliant patient and what that can charge someone with, and just how people's biases around these social determinants of health can come into play. Those were just some of the things we talked about.
That's really interesting, Sarah. Can you just say a little bit more about the use of language and non-compliant and why that's a problem?
Yeah, if a provider is calling a patient non-compliant, it may shift their judgment or may come from a place of not fully understanding. You know, if someone's not taking medication, maybe it's an issue of affording the medication. Maybe it's an issue of traveling to pick it up. Maybe it's an issue of the cognitive capacity, executive functioning to be able to maintain a schedule to take the medication. And so with a label like non-compliance, it kind of glosses over the very real impacts of these social determinants into someone's ability to engage fully with their health care, especially from the perspective of a medical professional who's just seeing, are they doing what I asked them to do, or are they doing what is quote unquote best for their health?
Mm-hmm.
So many value issues that come up with that that can really come into play.
Absolutely. And we see this around the world, you know, in my work in a global health context. Like one of the places that this has come up for me a lot is in labeling of mothers who don't seek prenatal care as non-compliant, and with no seeming understanding of the cultural pressures and marital pressures on those moms at home, where they are in active conflict with their husband over the medicalization of birth, where the husband would really like to use money on something else, not healthcare for a condition that he perceives to be normal and, you know, governed by God. Like, why would he spend his precious dimes on healthcare when this is the most natural thing in the world? And so there's conflict within the home. Then the women are getting it from the doctor's angle too, or the clinician's angle too, and really putting them in a bind. So I really like your emphasis on that. Thanks for bringing that forward. I think we can all think of a million examples of the same problem in our American context and in our local context here, not even bringing in a strong cultural angle, but, you know, so-and-so would very much like to seek their second dose of COVID vaccine, but in fact, their car broke down, or there was a snowstorm and they missed their appointment, or, you know, fill in the blank. And so the use of language is so important. Emily, would you help direct us to
Yes, so
participants in group 2?
yeah, group 2, we had Crystal, Janet, Janelle, and Robin.
Yes. This is Janet from the group, and I think the important points out of our group focused on, you know, of the both economic and social, and a very good shareable from one of our members was in the small community that she and her family currently reside in. There's a very good support network, and especially dealing with very clear problems with opioid issues, behavioral health, mental health issues, especially exacerbated with our COVID challenges. This also was commented on by another of our members who is in a much larger, I believe, urban area, in which there were connections made during, I would say, the earlier onsets of COVID, where issues of food insecurity, these transportation issues were looked at and addressed, and the, let's say, community infrastructure allowed some of these barriers to be mitigated somewhat. For instance, free bus transportation, delivery of food boxes to families clearly in need that needed to be quarantined. So again, looking at the social and the general community infrastructures, I commented on how identifying, you know, these infrastructure issues sometimes need to be fixed through legislative processes. And the specific area I was talking about, since I'm in a clinical practice, is barriers that people are experiencing due to insurance structures, specifically the cost sharing often that patients have.
Nice. You bring up such an important issue, Janet, and we actually do a training for our training center on how, as public health practitioners, we can talk with our elected officials, or say your county commissioner or legislators, because there are, especially if you work for the state, there are some boundaries around right, what people can say, and what they can say and what they can't say, I think is pretty easy to understand once you learn what the boundaries are. And you're absolutely right that that's a role that can be played by differently by different people on this call. Like yourself as a clinician might be able to have different conversations than somebody who works for the state already. And so I think that's such an important topic, and I encourage people to look for that training because I attended it myself and found it very instructive. Thank you. And group 3?
Group 3 was Alex, Joshua, Kara et al. Anyone from that group? That was Rebecca.
I think I was in that group as well, and I am the spokesperson, so I'll go ahead and go. My name is Rebecca, and I'm actually in the Department of Anthropology at the University of Montana in Missoula. And I'm also a programs coordinator for the Health and Medicine programs. And I'm currently working on a project to develop more experiential learning for students on campus so that it could be interprofessional. And we're thinking to use the social determinants of health actually as a framework, which is what brought me to this talk today. And in our group, we actually had a very diverse group. We had someone who has a dental hygienist background, who's sort of new to the public health sector. We have someone who has MPH, and then someone else who has an MPH, is a linguist and anthropologist, and then myself, who has experience in education anthropology. So we actually all had very different answers to begin. We talked a lot about the relationship between the social, the built environment, and the economics. But I think Joshua really brought up a good or an interesting concept sort of at the end of our discussion called toxic individuality. And this kind of came out of a discussion we were having about mask wearing, where we discovered that, you know, regionally, we all sort of see this, like you have people who are very willing to wear masks and others who just feel like, you know, it's not my problem. And I think this can actually, we felt that this actually reflects the larger issue within our different regions about whose problem is it? And that can sort of lead to some of these other factors. And so it's difficult for me as an anthropologist. I think I always think of the social first, because it's like, if we had a different mindset about the individual and how health is, like the fact that as an individual, it's my responsibility to take care of my own health needs, regardless of my situation, that creates more costs for someone who might have barriers because of their environment, because of their background, or even their genes for that matter. Whereas if we were a community that said, no, this isn't just an individual's issue, then that leads to more access to health. So I don't know if anyone in my group wants to add anything. Okay. That's kind of where we landed.
Thanks, Rebecca. That's really interesting. And it reminds me when recently the Surgeon General was visiting our state and went out to the tribes and spent a lot of time in Helena and talking with different groups of practitioners. Also spent some time on Zoom, I mean, not in person, but with us here at the School of Public Health. And I asked him, you know, one of his program areas was substance use disorder. And I asked him about what he, like, reflecting back on his time as Surgeon General, like what were his highlights. And he said there's no substance use disorder program in existence that works fundamentally without addressing the upstream effects. And he just launched into this whole description of the importance of understanding individual behavior in the broader social context that they live in, and how if you live in a place with no work and poor education and no access to healthcare and so on and so forth, you can't implement or even be a recipient of a substance use disorder program that doesn't address all of those other factors in order for it to be effective. And this was coming from, I mean, our Surgeon General, well, outgoing, but anesthesiologist, you know, somebody whose training and background is in a surgical theater, just wholly embracing social determinants approach and really moving us away from what Josh referred to as this sort of toxic individuality, which I think is a really interesting way of thinking about all of our behavior, whether it's pertaining to, you know, how we use masks or don't, but also how we think about health and people's agency or ability to enact behaviors that improve their own health in circumstances where, and the ability of anybody to, of any one person to enact it in a context which is filled with toxic individualism, from clinicians to on down, maybe including some of us inadvertently embracing by not even realizing it, this emphasis on what have you done to fix your health program or problem, instead of recognizing the context, mitigating against them. I think it's a sea change. And so long time coming. And as I was commenting, when some people were in the breakout rooms and some were still on the call, that's where public health started. I mean, we're sort of full circle coming back to this social context approach. But I think you could see reflected in my description of the history of public health as an industry or as a practice or as a passion, you know, that it did start with what we now call social determinants. So thank you for that language. That's really interesting to think about. And Emily, how about group 4? Who was in that group?
Group 4 included Brian, Chris, Lauren, and Melinda.
I'll speak for us. And I just wanted to comment on our last toxic individuality, and particularly with opioid crisis. There's a great book. I don't know if you all have seen it. It's called Chasing the Scream. And it was written by a journalist, so it's really engaging. I don't know if you've read like John Krakauer, but it's a similar writing style where you're just on the edge of your seat all the time, and suggests several things that do and do not work in addressing the opioid crisis. I thought it was really a great read.
Chasing the Scream?
Yeah,
Chris?
Chasing the Scream. I'll put it in the chat. I can't remember the author's name, but I'll put that in the chat. So when we talked about determinants in our group, we really kind of combined socioeconomic into one thing, and we were all from Helena. So so that's interesting that it worked out that way. But even here, somebody in our group said there's just really limited healthy choices that are affordable, and there's an inordinate amount of fast food. And so of course that influences people, particularly at the lower end of the social economic scale. And another person in our group mentioned like just the health literacy, like how do you access services? Like, I didn't know I was supposed to apply for Medicare. You know, how do people figure that out? What's the health literacy of the community? And then when we were talking about social determinants, 2 of us were geographic information specialist analysts, geographic information system analysts. And so Brian Norderud mentioned a couple of cool websites that look at these social determinants. One was Feeding America. And then the USDA has the ERDS database that looks at food deserts.
Yep.
And so people were talking about looking at evidence-based work. And then the last question, what would be useful for students, we barely got to talk about it all. We had to come back to the big group, and so we really didn't have any input there. The only thing, a student in our group said that she thinks these social determinants are the most helpful thing to her. And of course, I said geographic information systems. I think that's a good thing to look at as a student. The software is getting so much more user-friendly and so inexpensive these days. It's really it's really becoming accessible to everyone.
Such a good point, Chris, and you're going to love the next section, which does use a lot of geographical reasoning and helping people see that social determinants are geographically distributed. So thank you for bringing that up. And we do have a GIS certificate program here at the U if anybody's interested as a non-degree student learning more about GIS, but you can totally self-teach as well. There are a lot of useful resources out there. So the other thing I wanted to just reflect back on your remarks, Chris, is that so many people are spatial learners. And so seeing stuff on a map can make health information very available to people who might have a hard time understanding it displayed in other fashions. So I find that a lot with my students. So I'm really glad that we have some GIS people on here.
I think graphically, some people are just visual learners.
Yeah.
And so whether that's a photograph or a map or whatever, of course, I think maps are best, but I think it's good to try to talk to people in whatever way they can learn. And that means putting out your message in lots of different ways.
Yes. Emily, how about group 5? Who was in that group?
Group 5 included Cassandra, Stephanie, Tara, Terry, et al.
All right, so I'll go ahead and jump in. We really focused on a couple different areas, but we did talk about some economic stressors and how you can, go 5 blocks in a community or across the street and the quality of life is just vastly different, despite being, relatively close. But then the interesting thing came up, and I'm from Billings, so it's not really something that ever was on my radar, but that we do have, some tourist towns, some resort towns in Montana, and the cost of living is so high, but then we have a lot of, essential workers in those parts working in the tourist industry, and they're not paid enough money to, access quality healthcare. They don't have access to, high quality foods. There's a lot of, like other groups mentioned, fast food and convenience type foods, and they can't afford to live close to town because of the cost of living in those resort areas. And so really focusing on, we have essential workers, but Montana just in general, we have vast distances that people have to travel. And so the other thing that came up was just kind of the culture in Montana about, we don't really have the preventative or wellness models yet. We're really reactive. And also very conservative in the way that we access health. So people prolong getting care because we have this mentality that we're supposed to be able to pull ourselves up by our bootstraps. And so when people do access care, it's through the emergency room when things are pretty extreme, rather than addressing issues, before onset.
Mm-hmm. Gosh, there are so many things about rural and frontier communities of our own state. I know I've said this to you before, Stephanie, but that really just sounds so much like what we encounter in the global health sector, where people do have a mentality in so many corners of the world, like exactly what you're describing. But also what I'm concerned about as we see income inequality increase in our country is the increasing role of shame and stigma for people who are on the lower end of the spectrum in terms of access to resources, starting to feel like it's gotten to the point now that I just can't even go in. Like I am not dressed right. I've screwed this thing up and now I'm going to get yelled at, or I actually am feeling a sense that things have gone sideways and it's my fault. And so we see that so commonly in so many different settings. I think it's such an important point that you bring up, and just layer on top of that the shame and stigma piece, which really can compound problems. Well, you guys sure gave me a lot to think about in your feedback here, and a lot of your remarks actually presage some of the themes in the next section here, where we're looking at social determinants of health and practice. So let me just go ahead and launch in here. So this section helps us understand the evidence base on a lot of the themes that I've already referred to in my previous comments. So I've talked about access to parks and safe sidewalks. I've also talked about education and the role of educational attainment, and not talking about educational attainment with respect to health literacy, but just education period, education and literacy, and their association with longer life expectancy at birth, improved health and quality of life, and higher likelihood of health promoting behaviors being taken on by default. Things like getting regular physical activity, interaction with tobacco products, smoking, and the like, and also just going for routine checkups and recommended screenings. We see the rates of all of these things increase with education. This is why in many communities, people who are formally and technically employed in the public health sector are actually working heavily in the school system, either at the primary or secondary level, to get some of these behaviors to be so normalized that they do become default, and that just decreases spending on health and healthcare later on in people's lives. We also see, as I've alluded to, a very strong role of discrimination, stigma, and unfair treatment that can occur, of course, in any setting, but we also see specifically in social determinants of health framework some emphasis on, in many studies, on the role of this in the workplace. And we also know that discrimination increases a lot of negative health outcomes, like it has a known and measured impact on blood pressure, heart rate, psychosocial stress, and behavioral health outcomes, such as self-esteem, lower self-esteem, lower self-efficacy. When I talk about self-efficacy here, I'm referring specifically to one's sense that they can advocate for themselves and that a person can enact behaviors at their own volition, where those behaviors are preferably improving health outcomes. We also see family and community rejection coming into studies of the social determinants. Things like bullying, bullying of lesbian, gay, bisexual, and transgender youth has been a specific focus in recent years, and looking at the long-term health impacts of bullying for any reason. And those long-term negative health impacts are known to be associated with depression, use of illegal drugs, and suicidality. Of course, also I've talked, and I'm sure you well know, the role of diet and nutrition and the impact of that built environment on one's ability to eat nutritive foods and improve their health status by doing so. And here we see many studies associating nutritive diets with educational attainment, but also with the built environment, as I've referred to in, alluding to food deserts and the like. So we have some geographically minded folks on the call or in this webinar already, which is fabulous. And these maps that I'm going to show next draw from the evidence base on the social determinants that is geographical in nature. And so what we see in this body of literature is looking at locality, urban or rurality, but also a zip code analysis and all kinds of determinants or all kinds of outcomes associated with those geographical determinants. So this one here gets us off on this path and just helps us look at life expectancy at birth in years, and shows the dramatic impact in some communities of location. And so I'm sure that in the next couple of slides, you're going to start to see something jump at you from the state of Montana very plainly for those of us in this webinar who are Montanans. Anybody want to take a swing at what I'm alluding to here? What do you see in the state of Montana jumping out at you in terms of life expectancy? Does anybody know what these orange counties are and the red one? or what's there.
Reservations.
Yeah.
Probably.
Yeah. So those are our three of our counties where there are large reservations and reservation populations of Native American people. And unfortunately, we are, I think, all aware that health outcomes in those communities tend to be poor for a wide variety of reasons. Zip code has been extensively used in a much more refined fashion, even within neighborhoods within the same city. And so this here is Chicago, and over here is the intersection of two major roadways through the state of Mississippi. And we can just see the impact of location on life expectancy here. So the lowest on this slide to the left being 69 years, south side of Chicago, the highest being Chicago's urban center, and the north side, the wealthy and affluent neighborhoods to the north. This slide shows other attributes of the geographic community. This is depicted in terms of homicide rates, which is a feature of the built environment, which is frequently modeled in social determinant analyses. And here we see the homicide rate per 100,000 residents and how heavily determined these rates are by geography. So these are 2016 data, and just show for Brooklyn and Chicago, those neighborhoods that are most highly associated with poor health outcome, very poor health outcomes here. I think it sounded like some of our GIS people are food security and food insecurity minded, which is a very interesting area of research, as those folks will know. Here we have, for Mississippi and Illinois, some county level data, which show food insecurity rates and the clustering of those higher rates by geography. So counties along Mississippi's eastern border having very high rates of food insecurity, and here a few counties with relatively low rates, and then Illinois, you can see the same sorts of features. So these kinds of studies are extensive, and this relationship is well documented. Here we have, again in Chicago, a set of maps where one outcome is sort of layered on top of another, or could potentially be layered on top of another. Here they're pulled apart in three different maps of the same place. These are all Chicago. The one on the left is food deserts. In the middle, we have life expectancy. And on the right, we have unemployment. And you can see how these things cluster together. And if we were to layer them one on top of the other, that association would jump out as well. And so one of the things that the GIS approach to understanding social determinants allows us to do is just to display this graphically in a map form, like we were saying, appeals to many different learners. And some of your stakeholders and constituents might be able to receive and comprehend health information in this way better than in a tabular fashion or graphs of data or text form. Child poverty rates by country this has also been modeled. And again, for our state in Montana, you will see the counties with reservation populations jumping right out at us. And so that geographical relationship, again, is clear. More recently, there have been a slew of mapping or GIS exercises looking at COVID and its differential impact on communities. This one was something we sort of talked a lot about last summer, and having to do with usage of vacation rentals and the relationship between vacation rentals and COVID prevalence. And this was, quite early days in the in the pandemic, but already there were some things that were jumping out at us where influxes into this state of folks from out of state seeking lower COVID rates that we had at the beginning were driving up rates in some of these localities. Whitefish, Big Sky certainly jumped out when I first looked at this. I want to drill down now into specific health outcomes having to do with maternal and child, just to get a little bit more detailed. Some analyses have focused on, for instance, obesity among pregnant women. And so we know about 12% of pregnant women smoke during pregnancy. About another 12% have consumed alcohol in the past 30 days of the onset of this study. We also know of women who could get pregnant, 69% are not taking recommended folic acid supplements, and about 1 in 10 are depressed during any trimester of pregnancy or during any month within the first year after delivery. We can see from the GIS way of looking at this relationship, we can also see obesity and its geographical distribution. And again, in Montana, we can see certain counties are jumping out at us and can help us understand, say, for instance, those of us who are interested in maternal health, where geographically some efforts might be focused for targeting obesity-related programming. So looking at the smoking rates, here we see a geographical presentation of those states that smoke the most. I think we have a lot of Coloradans and Montanans both on the call. Colorado generally does a bit better than Montana on a lot of different health behavioral outcomes, and certainly smoking is one of them. Moving on to the drug overdose rate per 10,000, these data are from the years spanning 2009 to 2018 and show us again some of the geographical distribution of this particular crisis in the state of Montana. So the crosshatched parts of the state are reservation communities, and then we can see you know, the rates coded by color, and again, certain counties jumping out at us. And unfortunately, again, we see a relationship between geographical considerations like where reservation communities are. We know that children's health is profoundly affected clearly by substance use disorder and pregnancy and its impacts on health outcomes and mortality. But we, in addition to that, understand that children's health is also affected by things like income, educational attainment, particularly of the mother, and community supports to healthy behaviors. But when we add in rurality to that picture, as we always have to in our state, we also see that for children, rurality adds a whole other layer. Higher rates of poverty, they're more likely to be insured by Medicaid, they're more likely to struggle with obesity and obesity-related disease, they're less likely to receive preventive medical or oral health care, and also more likely to die than their urban counterparts across the board. When we disaggregate these data, we recognize that that death rate is mainly due to unintentional injury and contributes overall to those higher rates. What we see here in these two figures are for women of childbearing age and infants, what are the major health issues? And we can see the relative role of each of these things. So access to medical and primary health care occupying the biggest chunk here, obesity and overweight. Here, lack of family planning, problems or access to reproductive health care over here, and then lack of education. For infants, we see premature birth, poor nutrition, parents' lack of education, particularly in the mother, lacking immunizations and vaccines, a truncated or absent period of exclusive breastfeeding, and access to healthcare, all sort of quite evenly distributed as contributors to major health issues for infants. So when we look at the way forward, bearing all of these things in mind, we see that experts are recommending that for social determinants of health initiatives targeting maternal child health, that we should focus on programs to bolster provider availability and increasing financial access to care, either through the ACA or other approaches, including grant-supported activities with specific operational targets. And I could see that reflected in the comments of some of the folks in, I think it was group 4, looking at my notes here, talking about access to insurance and other schemes to help pay for healthcare. I would say that the above go without saying practically, but what else can be done? As public health practitioners, we can contribute very substantially through improved surveillance, because without it, we can't define problems, and we can't document how policy solutions are or aren't working. When we conduct surveillance of our communities, we should always make sure to include features of the social environment that are relevant. Things like, for instance, ability to exercise or ability to purchase nutritious food. We also want to always kind of think in creative ways about methods of delivering healthcare or education to the communities that we work in, if we're in rural areas. And the use of mobile vans or buses has been on the uptick in our state to do this. And our role as public health practitioners is to determine for what purpose would these kinds of mobile outreach efforts be visiting our communities. Also, and particularly as a result of changing strategies of healthcare delivery because of the pandemic, we see an increasing emphasis on telehealth and telemedicine. This needs to be available to people. So people need to have the bandwidth for internet usage of these services, but it also has to be practical. In other words, available to people when they're not at work and relevant to them. In other words, providing advice that they can actually use in their lives. We can see in our new Governor Gianforte's agenda for his first year in office, a pivot toward telehealth and telemedicine programs. So I'm quite buoyed and encouraged by that. How that's going to roll out, I'm not sure, but I was really pleased to see that on his agenda. I want to go back to improved surveillance, because I think it's really important that as public health practitioners, we recognize that one of our roles is to serve as interlocutors or communicators between our community and folks folks sort of up the chain from us in the public health system. And so I wanted to show some things. Emily, can you please let me know if you can see the screen when I'm sharing my my web browser?
I don't see it yet.
Oh, okay. I think I need to change my screen share like this. Now, do you see Healthy People 2020?
Yep.
Ah, excellent. Okay, so if you guys were to go on the Healthy People 2020 website, one of the things that you will see are tabs to look at different life stages and determinants by life stage. That is, if you click first on the social determinants tab, then it brings you to this one. So you can click here, and then you can also click on latest data. And I would encourage you to look through that, because those data will orient you to what data you want to collect in your community. The other thing that I would encourage is that you go over to Healthy People 2030. So this is that website that I talked about before, which is, I don't like it quite as much as 2020, like I said, but it does have some really useful stuff on it. And one of the best things is to be found right here on the front page. This is the leading health indicators. As it says here, it's a small subset of high priority objectives selected to drive action toward improving health and well-being. So if we click on this, it gives us the next page. They have it sort of, you can click on different ages, but this is all ages on the first page here. And so you could click on any one of these, and clicking around for it to find what I wanted to share with you guys. I went to reduce household food insecurity, and in doing so, reduce hunger. And so if we click here on learn more about data measurement for this objective, it tells us specifically how you want to measure that in your community. It tells you what your numerator should be and what your denominator should be. And then you can click on other linkable places here, or linked places here, which will give you even more information on how to do this measurement. So like here, the numerator is number of households classified as food insecure, including low food security and very low food security. Now you might be sitting there wondering, what's the difference between low and very low? And you need to know that. So then you can click on the other links and it will help define that for you. So I think that kind of thing is extremely useful. And in a few minutes in my slides, I will share some other tools that will also help you with that. Okay, I'm going to pop back over to my slides here. Okay, so that brings us to polls number 2 and 3. And this has to do with for women and separately for children in your community, what would you say are the most important social determinants of health? And that could be different than what you answered before, because before you were just saying like generally for this community that I live in, it's XYZ. Now we're drilling down specifically into women or children. Women and children, excuse me. Well, we're very close to everyone having voted. So I can see here that again, economic stability is a front runner, followed by education and social and community for children. And again, very similar, but a little more powerfully, economic stability for women. I'd like to know more about that. So can you guys go back into your discussion groups and let us know and let each other know, and then your spokesperson can report back to the group. Thank you. Thanks, Emily, for arranging people.
Yeah, they'll be in the same groups. How long do you want them?
Let's just do a 5-minute discussion.
Okay.
Are we up to time, Emily?
Yes, ma'am.
Excellent. Well, let's go with group number 1. Sarah, are you still your group's person?
I sure am. So we talked a lot about how it felt challenging to differentiate between some of these social determinants when asking these questions, especially in talking about raising children, because while economic stability can be a protective factor in terms of where somebody lives, the resources one has access to, there's also factors such as culture and community. And if there are not substantial economic resources available, but you have someone you trust to watch your kid or to make you food for an evening, that can really, or to take your child to maybe pick up their medication or to go to their health appointment, that can really help balance out some of these other resources that might be more lacking in the community. So that was a big focus of our conversation.
For both pregnant women and children.
Yeah, I think with thinking about adults, it was more, or actually thinking about with children, it was more directly the economics that they would perceive and they would feel the impact of. And we also spoke about how just kind of in our capitalist society, like everything it does come kind of back to economic stability in a sense. And my cat does love to come up on Zoom meetings right when I'm talking. Yeah, that was the strongest focus of our conversation.
Interesting. Okay, thank you. You're gonna hear echoes of that in the case studies I present next. Janet, how about group 2?
One of the examples given was the impact of closure of the local regional hospital, OB unit closure. And then the clear effect on the community having to potentially, travel several hours outside of the community, which then also had sort of the effect that many of the moms who may have given birth outside of the community would often then choose to continue child health care outside of the community. So that's sort of an interesting downriver effect of that. And the economic, I think, instability that many of the pregnant women that I'm aware of is often, related to their single mom status, being in multi-generational families, and often being, the not necessarily sole breadwinner, but certainly a major financial support within their family structure.
Right. So those all link back to the poll findings on the strong role of economic stability or lack thereof. And then just to make sure I understand, and for other people, you're saying when the local OB unit closed and then people were delivering in a place that they had to drive some hours to, that they would establish care for their children there while they were at it. And then it just was like increasing travel times for both maternity and pediatric care.
That's my understanding of what the comment was. And I think I get it. Having a head nod over here.
Okay. Interesting. Thank you. Rebecca, do you want to do group 3 again? Thanks, Jana.
Yeah, sure. So our group really focused a lot on the economic stability piece, both mostly for women, and then more of the built and environmental piece for children. And again, with the economics, we kind of discussed the social, because you have this element of gender inequality that can impact how a woman is able to care for her child. Because if, like Mary mentioned, she's a nurse from a rural community, and she mentioned that, in that area, if you're a female, it is harder to find a job, and a good paying job. She said even anecdotally, when her son and daughter were both adults looking for work, her son had a very easy time getting calls every day, while her daughter struggled to find work. So that's one element. Another element being breastfeeding. Being able to pump or take breaks for pumping in the workplace can be a challenge. And then the final piece we kind of discussed for children is this, like the environment where there aren't playgrounds, there's not access to really safe outdoor spaces for children to play and have that sort of, so that was kind of where we landed. And then one final thought was just that, education can play a role, because if students are going to school, they may have access to services that they wouldn't in their home environment. So it can help bridge that gap. Just having like the school nurse or screenings, that sort of thing. Yeah, so unless my group wants to add anything, I think that sums up what we discussed.
Excellent. Thank you, Rebecca. And for group 4, Chris?
Melinda's going to take it.
Melinda.
Yep.
So our group, by and large, felt that economic factors were the most important for children.
Okay.
With the sort of general statement that it is hard to manage your health when you're struggling to make ends meet. We did have one member of the group who felt that given the amount of time children spend among their peers, that education and the social and community aspects were more important. And then we had a brief discussion about how factors, including whether or not your school provides food, can be really important. Especially during a pandemic, there are schools that are offering food for kids who are not attending school. But at least here in Helena, in the school district or at the school that my child goes to, we have heard that the uptake is not good. Kids were eating this food when they were at school, but they are not getting it when they're remote, and it is not clear why. For pregnant women, by and large, the group felt the same. They marked the same factors for both groups, with the exception of one who felt that the economic factors were more important for pregnant women and that the peer group was less important. But overall, people felt that the primary factors were the economic, education, and social and community.
Economic factors pertaining to like ability to find employment, or if employed, ability to either look after children or attend like prenatal or well-child checks and that sort of thing.
Yeah, and the sort of cost of having a child, generally speaking, the
Okay, got it.
factors were really significant sort of in all areas. Being able to afford healthy foods while pregnant, et cetera, and all of the other things that come with pregnancy.
I see. Okay, really interesting. Thank you. And I'll remember these things and make connections when I can in the case studies that I lay out next. And who will speak for group 5? Will that be Steph again?
No, it's Elena.
Hi.
Hi. So, pardon me. We had a number of people, 5 in a group, and one person really didn't, she couldn't relate because of the situation. She was dealing with maternal child health. But overall, we decided that pretty much all of us selected all of the choices for both the children and parents. And the reason why we selected all of the choices is because children by themselves, the situation is not in a bubble. Their parental situation impacts how the children's situation, how the children situations are. And so one of my colleagues mentioned that overburdened nonprofit resources, that communities rely heavily on these nonprofit resources, maybe for food or whatever. And unfortunately, that overburdens the system and overburdens the nonprofit, and it kind of lessens the impact that they can do if they're trying to help so many people and they don't have the resources to do so. Another person mentioned access to care, access to free programs, and the stigma behind it. And he mentioned that in his area, some of the programs like WIC are actually not using all the resources, and a lot of the reasons is the stigma attached to having these using free programs. But not only that, it's sometimes the policies and the procedures around getting access to these programs makes it difficult. If you have a child who has Medicaid, why do you have to go back every year to sign your kid up when, I mean, the situation hasn't changed, you know? It's just the fact that they make it hard for people to get the care, to get access to these programs. And it's like they want them to have access to these programs, but they also want them to stay poor, kind of. It's a strange economy. It's like you can have access to the programs, but you can only have this amount of resources. And if you go 1 cent over that amount of resources, then they cut off your access to care. Instead of giving you opportunities to continue to build on the resources you need so that you could eventually stop access to all of these free processes, once you're in a stable stable economic whatever situation. So overall, our group believes that there is a connection between the parental situation and the child situation. So, and we think that all of those factors play a role in it.
And Elena, are you in the state of Wyoming? I'm looking
Yes.
at your title on that is in front of your picture. That's really interesting. And I really think, those, the overburdened nature of, the sentiment that people have with respect to their ability to access some of those programs, it really connects with educational attainment and health literacy combined, I think, as well as self-efficacy. Somebody's ability to advocate for themselves in the face of, maybe somebody that they feel intimidated in front of or by or what have you, I think can play a massive role in what you're talking about. So that's going to be evidenced in some of the studies actually that I share with you all next. Okay, I'm going to share my screen here and go back to where we were in my presentation. So thank you so much for sharing some of those thoughts, because that definitely informs the way that I'm thinking about what I'm going to cover next in our third session here. So our third session here looks at social cohesion and interaction between communities and healthcare facilities, as well as a couple of studies that look at the use of the social determinants of health framework in intervention or in programming for seniors, and also the built environment. So with respect to the social determinants of health and social cohesion, I wanted to first remind you that on Healthy People 2020, one of the reasons I love that site is because they did publish so many different studies that have helped establish the evidence base for this framework or this model of going about health program planning and execution. So one of the findings is that relationships are important for social cohesion and that these both relate to health outcomes. When we talk about social cohesion and relationships, we're specifically referring to social capital, social networks, and social support. So let me define those. So somebody who has social capital is somebody who has connections to others that help them specifically, that they can count on in times of trouble, and who can count on them in turn. And you can't have social capital if you don't have social networks. So a social network refers specifically to the number of and kind of social connections a person has. Can their social connections get them a job? Can they get them an expedited appointment with a specialist? And that sort of thing. A social network is it refers generally to the community of people upon whom we can exercise our social capital. Obviously, it goes without saying that some people have much higher social capital than other people. Some people are connected. But when we think about health, it's really important to think about whether the communities that we're working in have individuals with enough social capital or the kind of social capital that enables them to use whatever health literacy and education that they have to affect their health care and health outcomes. And oftentimes those are very widely disparate between communities and also within communities. So for instance, it would be erroneous to imagine that, say for instance, everybody within, say, the state of Montana tribal community, everybody has low social capital. That's not true. Many people within tribal communities have very high social capital and can exercise it extremely effectively, while others cannot. And so one of the things that we learn in social anthropology and medical anthropology is of the paramount importance of disaggregating communities and understanding differences within communities of all kinds, but certainly, any social anthropologists or cultural anthropologists in the land will tell you that one of the most important things to avoid is thinking of any community as a monolithic entity, that all communities have, huge amounts of disparity within them. And obviously communities have huge amounts of disparity with or between them in our country. The last piece here is social support. That refers to things like emotional support. And that I'm referring here to the feeling that someone has your back when you're sick and can, for instance, give you a ride to the clinic or the hospital. And so we just distinguish between these three sort of vectors or elements of social cohesion: social capital, social networks, and social support. All of these things together have an important impact on health. For instance, using 4 measures of social capital, like lots of scholarship and research has been done to help us understand how we measure social capital. But one commonly used approach is to distinguish this into 4 features. One would be perceived fairness of other people towards oneself. One would be perceived helpfulness. And one would be group membership. And that means, group membership in something like a social group or a church. And then the last would be trust. And so one study of the relationship between these features and health showed that as people measured higher or scored higher on these 4 metrics of social capital, their health outcomes were also better. We also see that looking across communities, that as income inequality increases, social capital decreases. And so that's another feature that we've come to learn about this way of looking at differences between and among individuals. We also see in studies of social cohesion and their relationship with community and community and health is that the collective efficacy of a group is also important. And so that refers to a community's mutual trust and ability to create change and exercise informal social control via norms, etc. And so that might apply or pertain to when a community feels like it can govern itself in a way in terms of the influence of norms on behavior. What is acceptable, what is not acceptable within communities. Also, a community's ability to collectively practice rituals that are important to it have also been shown to be extremely important and associated with health outcomes. And so one of our graduate students here in our program at the University of Montana currently is studying among people in Native communities or Native populations in the state of Montana, how is their ability to access and practice traditional ritual or ceremonial behavior associated with both efficacy as well as health outcomes. And so this kind of approach to understanding health is pretty new and very much centered in the social determinants of health framework or approach. We also see that social networks can spread social capital as well as health behaviors and outcomes. So this is referred to as social contagion, and many studies have demonstrated this effect. So if for instance, if your friend, sibling, or spouse is obese, your likelihood of becoming obese increases. And the finding is the same in lots of different research studies in different communities for the behaviors of drinking and smoking. We also see that high levels of social support influence health outcomes through psychological and behavioral pathways. Like there are studies demonstrating that social support helps people stick to healthier diets, reduce emotional stress, and that both of these pathways can affect biological functioning in different bodily systems. We also see the protective nature of social support being especially important in so-called minority populations or non-mainstream populations, and the evidence to this effect is pretty abundant. One study showed that higher levels of social support actually acted as a barrier against the harmful health effects of discrimination among Mexican American women in California. So there are lots of this kind of study that you can find in the literature, further establishing the evidence base of the connection between social cohesion and health. when we look at studies and interventions, we see them occurring, or studies of interventions, we see interventions occurring at multiple levels. Some are focused on the household level, others on groups of people, others are geographically focused, like on neighborhoods. And typically, it's quite common to see cross-sector collaborations coming into play. And so when I talk about cross-sector collaborations, I mean collaborations that I've alluded to previously today between like people who are active in the education sphere, people who are active in the housing sphere, and public health. So we see people like us and public health practitioners reaching out to our counterparts in the housing office or in the formal schooling or school system and working together. What I would say, like generally speaking, to sort of sum up some of these remarks, is that most transformative social determinants of health interventions demonstrate unconventional thinking and program staff using relationships with other stakeholders in the health system to mobilize new ideas and new energy. And you see people really thinking outside of the box, like knitting together the efforts of academics and lawmakers, or academics and public health practitioners, or lawmakers and public health practitioners in new ways, and spearheading new bills that go to the legislature, or new local level policies, et cetera. And so, I mean, I find the social determinants of health perspective and that framework that's looking at those 5 areas to be quite inclusive, quite holistic, but also really liberating, because it kind of gives you license to think outside of the box and start thinking creatively and in a less sort of formulaic fashion about the ways that we can sculpt programs to our communities that we work in to specifically meet the needs that are pertinent there. I want to talk next about social determinants health and programs focusing on seniors. I know a lot of us work in communities with a pretty high median age and a lot of elderly people. And so this is an area that we see a lot of work and scholarship being done, or program initiatives being focused on by our graduate students in our program, focused on things like falls and preventing falls in our senior population. One study from 2012 that I wanted to highlight for you connects some of the pieces that I've presented already today. A finding is that healthy aging for rural seniors extends significantly beyond access to health care. And when we look at housing, we see that there is an insufficient supply of appropriate housing that's appropriate for seniors, meaning 1 story with safe entrances, that there is a widespread preference for condominium living when seniors are surveyed, but it's rarely available. People prefer it because they can downsize. It allows them to carpool more effectively and more efficiently to get food or to seek healthcare or what have you. And also for social life, where people can just avail themselves of community events without having to go far. Card games, board games, other social interactions get easier to arrange. And so the housing angle on health for seniors has turned out to be a very important one in the social determinants approach to seniors. We also see that transportation is a big part of many initiatives using the social determinants approach to seniors, because transportation is such a huge barrier or challenge. People don't have their license anymore, or they're observing self-imposed driving restrictions. And many studies also show that seniors don't want to ask for help because they find it, humiliating or aversive in different ways to admit that they're not driving anymore. But beyond housing and transportation, many seniors need help with finances. They don't have caregivers to come to their homes and falls, as I said before. So all of these pieces come to play a significant role in lots of initiatives that are pursued under this framework. We really see an emerging emphasis on very practical interventions like initiatives that use a wraparound care approach that consider all of the elements on the previous slide. Home care that includes not just health in the home, but other things that seniors also need help with that wouldn't be conventionally thought of as related to health, but do impact their health. They need help with housekeeping and assistance with outdoor chores like snow shoveling. So some of the social determinants influenced programming that we're seeing includes elements like this. It's not just like, you know, rehab for hip injuries from falls anymore. It's much more preventive care. It's much more holistic wraparound like this. And rerouting of funding. So an emphasis in programming and initiatives on preventing health problems before they begin, and by putting into place social programs that ensure that can happen, and also thinking creatively and innovatively about addressing needs before they turn into healthcare problems, like what I was saying before, providing a snow shoveling initiative, which helps seniors, have been demonstrated to help seniors avoid falls, which means they avoid costly healthcare, PT, OT, etc. So, I mean, it all fits together. And so we see this kind of creative thinking outside of the box where, you know, you might come to work in your public health role, or, you know, I know numerous people on the call are relatively new to public health. You might not have thought before that one of the things that you might engage in is a snow shoveling program. But lo and behold, when you start thinking more creatively and using this approach, you can see the connection is there, and the evidence is there as well. I've referred previously to the Radon study. I love this one because it connects the built environment with educational attainment. So this is a study by Larson et al. Was published in 2011. So radon causes 21,000 lung cancer deaths, or is thought to be associated with 21,000 lung cancer deaths annually. And it's a big problem where we live out west. Here, it's naturally occurring in the soil of many of our neighborhoods, and to a higher degree in different localities. It is a very significant housing problem for rural people. And there are some elements that contribute to it that have been uncovered by people taking this social determinants approach. Economic segregation, where poorer people are more likely to live in places with higher radon, with community gentrification, and with displacement of lower income families to unincorporated parts of counties where radon testing is not required, or typically undertaken by realtors or, you know, home inspectors, or even recommended. And so this makes understanding and troubleshooting the challenge a little more difficult in some places. But this study looked at a couple of different things. They looked at socioeconomic status, or SES. They boiled that down to income. Do people rent or own? What is their partner status? What's their educational status or educational attainment? And how many children do they have living at home? But they also looked at cognitive variables. What were their, how did they score on tests of knowledge of radon and its dangers, and also their own personal risk perception, and also their self-efficacy score. In other words, their ability to advocate for themselves when having identified an issue that needed change or assistance. And what the study showed in the results was that homes were rarely tested in rural places. Nearly half of residents in the study area had never heard of the harmful effects of radon, but that more highly educated residents, not educated on radon, just highly educated in terms of grade level attainment, were 5 times more likely to have tested their homes. And the education variable turned out to be more powerful than either self-efficacy or income, which is so interesting. It really underscores the importance of the relationship between educational attainment and self-efficacy, and the willingness of people to advocate for themselves based on the amount of education that they've achieved. It also underscores the critical importance of education in affecting behavior linked with this particular housing and environmental hazard, and the intersection of two of these kind of what I've referred to as like buckets of the social determinants, bringing together education and its interaction with housing and their combined effect on health outcomes. In terms of ways forward, when we're thinking about our work as practitioners, we have to think in terms of very practical interventions, like I was saying before. First of all, we do want to advocate for supports to the education system whenever we can as public health practitioners. Again, like with snow shoveling, you might not have thought coming into your role as public health practitioner that one of the chief things that you would do would be to advocate for for children to stay in school for as long as possible. But lo and behold, it turns out to be one of the most powerful effects on long-term health outcomes. So in addition to community health outreach work that we do, we can also provide messaging or encouragement or nudges to the families that we support and the children in them to keep those kids in school. And beyond that, and as alluded to in a lot of the remarks that you guys shared back from your group conversations, we need to also support health, nutrition, and vaccination programs in school that support attendance and persistence in schooling or persistence across the grades. So coordinating with other county departments about the significance of, say, for instance, the radon problem, maybe that's your cup of tea. Maybe radon isn't a big problem in your community, or it is a big problem, but other initiatives are more interesting to you, that's totally fine. But if your training or background or particular interests lean you toward the built environment in terms of housing, radon might be something that would be very interesting for you to delve into and to start thinking about as a possible initiative that you could build some programming around. If so, dissemination of appropriate public health information about that would be something that you would involve yourself in, but also outreach to home inspectors or realtors with flyers or other materials to help educate them and their clients on the significance of the radon problem and how to mitigate it. And I'm picking radon because I liked the study, but there are lots of different examples other than radon that you could apply this kind of thinking to in terms of broadening your work beyond some of the conventional things that people are doing in health departments, like, you know, conventionally vaccines, tobacco cessation, or what have you. There are other things that that if you had time, which I know a lot of people don't, but if you had the time and energy, would be things that you could enact programming around. Where would you begin? So as COVID-19 has abundantly revealed, our public health system's got some key weak points. One is that operational funding is pretty weak. Unfortunately, we respond constantly to grant funded or grant funding opportunities or something similar to that. And so oftentimes we find ourselves kind of stuck on this cycle of responding to requests for proposals and then doing the thing that we got funded to do. And then toward the end of that cycle, you look for other grants and you chase those and do what you promised you would do if you get the funding. And unfortunately, not all of those funding initiatives are at the top of the list of local people's needs. And that's a constant tension that we see across practitioners. Now, how we start to move away from that depends fundamentally on stakeholder involvement and also on what we refer to in our field of, you know, social and behavioral sciences and public health as participatory research methods for needs assessments. And these things together can identify needs together with the help of the communities that we work in. And if you're interested in learning more about identifying stakeholders or doing participatory research methods, our Public Health Training Center also offers trainings on those topics. But if you had those things on board and you were engaging in those activities, it would allow more social determinants of health informed education through flyers or outreach or person-to-person interactions with patients, but also, and I think even perhaps more critically, with opinion leaders in the community that you work in, and other key stakeholders, county commissioners and elected officials, et cetera. So really reinventing the wheel needs to happen because there are tools galore out there to help you with this work. And that's what my next slide is about. So experts who use the social determinants of health approach have developed some screening tools and some questionnaires or really simple ways of identifying needs in your community and then developing programming based on what you've identified. And so these three that I've listed here through AAFP, through the Prepare tool, and through CMS are excellent examples of that. And I provided links to them all in the Word document that went out, the program for today's training. So if you look on the second page of that at the bottom, those are hyperlinked. The same things that you see here are all hyperlinks. So you can click on those and that will take you to the tool. So I'm gonna share a different screen here. Darn, I might have closed the window, but I'll bring it up in the next session. We'll have one more little break, and I wanted to bring up one of these tools just to show you briefly what that would look like, so that you can see exactly what I'm referring to. Let's go ahead and do polls 4 and 5. Emily, if I could get your help in putting these up on the screen. So I want to hear from you about what you think in your community for seniors and also men, because so far a lot of my remarks have been kind of oriented towards women and children, but that is not to neglect the needs of men in our communities, but also seniors. So I'm interested in where you would rank for men first, and secondly for seniors, these various social determinants. And I am going to try and bring up that other screen while you guys do that. So just 1 second here while you do that poll. Wow, that's really interesting. So here we see economic stability falling behind and social and community context pulling forward for men. How fascinating. Thank you, Emily, for arranging that poll and sharing the results. Okay, so for men, social and community context scored highest, and for seniors, health and healthcare. Interesting. We are gonna go back into our rooms for one last time. Where are we up to on time? Oh, it's just 11. Okay, so we have just an hour left. Before I put you guys back in your rooms to let us know, or each other and then us as a group know what you meant here by choosing these things, which came out quite differently than for women and children. Here's one of those screening tools that I referred to on the last slide. So this is the AAFP one, American Academy of Family Physicians one. And, if you guys scroll through or just do some clicking around the internet, you'll see that the social determinants of health approach has really been embraced by a number of different communities of clinicians, including the AAFP. And so now we all probably know from going into the doctor's office that we are routinely screened these days for things that would easily fall under social determinants of health approach. And so this is a tool that was developed for looking at, people that you interact with on a regular basis in your community. And if you look on the screen here, I'll just scroll down, you can see this is a 15-point screening. The questions are very simple and the scoring instructions are provided at the bottom. And so this just helps you kind of take the temperature of your community or a group within it, maybe a neighborhood or a particular subset of the community, and helps you understand where they fall, where they are scoring on these different attributes of the social factors that are contributing or understood to be contributing to health outcomes. So that's just one of a number of tools that I linked you to on the handout that you could refer to in the future. Okay, So I will just go back over to here. And we'll put you back into those breakout rooms. And so we can have a brief discussion of this question, these two questions, and then we will reconvene after our final break, which I think we can do our final break just for 5 minutes. So let's have you in the discussion room for 10 minutes, do a 5-minute break, and then we'll reconvene for our final session.
Did you say 10 minutes in the breakout room?
Yeah, let's do 10 minutes of breakout room. We'll do a 5-minute break for bathroom or what have you, and then we'll finish up.
Perfect. You should see invites to your rooms again.
Emily, are you are you there still?
Yes, ma'am.
I think we can get started again.
Sounds good.
So I guess we would start off by hearing briefly from Sarah in group 1, or whoever group 1's person is this time around. So
it's still me.
we have Sarah.
Happy to be trusted with speaking for my group. We had some really great, rich discussion, and just the challenge and of kind of divvying up populations, of divvying up social determinants when so much feels like it overlaps. And it was helpful to think about these individual populations as they're outside a lot of what people in the people in my group usually work with, and why, how a lot of our conversation has been geared toward women and children, and kind of the specific needs of male and elderly populations. And the challenge of education, especially health education with men and masculine presenting people, just not necessarily having as much built-in health education. And so that was seen as a nod for social context, as modeling can really help kind of overcome some of those educational barriers if you have socialization with people who are plugged into their health. And social context came up a lot as we talked about seniors as well, and that's one that can be changed more easily oftentimes, whereas economic status, by the time you're a senior, you kind of have a situation that, either you have support for retirement for your old age, or you don't, whereas social constructs can really help make smaller changes where economic changes are maybe more of a barrier. So it was, again, hard for us to pick one or to identify most powerful. It fostered some really great conversation.
It sounds like it. Thank you for sharing that. I know in my work with maternal health relating to the interbirth interval and making sure that women feel like they can access family planning, that one of the just experiential findings personally has to do with the fact that, gosh, in that area of healthcare, if you're only talking to women, you're not going to get very far, especially in different cultural contexts where men have control over that decision making, and the marital power that is shared or not shared equally between husbands and wives or partners. Boy, does that ever play a role. And so I really appreciate what you're referring to there with men, and specifically the challenge of health education outreach to men, when people might think, oh, well, men don't need this particular kind of health education because family planning is, more women's area or something like that. It's a really common attitude in lots of nations. And boy, that has not proven to be the case. So I do appreciate you sharing that. Janet, are you speaking for group 2 again?
I can, thank you. I would say our group had sort of very similar conversation in regards to the absence of social support systems for men, and that often leads to some of the greater impact on drug and alcohol addictions. I can also probably give some personal observations is that often then if long-term relationships, men lose their wives, oftentimes then they really are totally lost in terms of how to take care of themselves. Obviously, that's not a full, blanket statement, but it does seem to be a pattern. I can also, our discussion sort of looked at the clear impact that COVID has been having on seniors and, the lack of socialization and how that clearly has been impacting on increased depression in that population. One of the comments I made is I see in this country that in medicine especially, we tend to not, we look at seniors, unfortunately, as, a less diverse group. I mean, that you reach a certain age and all of a sudden you are a senior and here you are, you have supposedly all these, potential limitations, which clearly is not the case. I mean, our seniors are much more stratified in their own health status, but also in their clear areas of interest and such. So, to look at seniors as this one cohesive group is very misleading. I also feel that in this country, we definitely silo our seniors off into especially housing groups, quote, senior housing, which lack multi-generational options, which I do feel is not a benefit at all.
Mm-hmm. Such a good point. I love that. Going back to the importance of disaggregating groups, and understanding needs within them. It's so important. Thank you. Rebecca, are you for group 3 again?
I agreed to take that on.
Okay, Annie.
Rebecca a break.
Okay, excellent.
Yeah, so our group, we talked about a pretty strong sense that economic concerns are some of the biggest that influence health for men. And we spent the majority of our time talking about men as a demographic group. And I think there was sort of a subset in our conversation, or a subtopic in our conversation around health behaviors and how cultures influence that, and in particular in Montana, a cowboy culture, and just the way that influences behavior choices and behavior, those sorts of choices around healthcare. We also got into sort of a side conversation about ways, some of the innovations for trying to address healthcare costs and the economic barriers to it, and around subscription models and some of the other things that people are trying to address. I know in Colorado, there's a pretty big emphasis on trying to come up with some political solutions to healthcare costs, but I think sometimes it's often at the periphery of that health system. And I think it's really notable that I think men, in as much as that's one of the important drivers for their health outcomes, the economic piece has to be addressed in some way. So that was the bulk of what we were talking about.
Thank you, Annie. That's really interesting. I need to learn more about Colorado subscription models, because big challenge in so many places. Group 4, I guess it was either Chris or Melinda before, but maybe somebody new this time. Melinda.
Oh, sorry, I think it might have been Chris Carlson who was going to speak this time.
Chris.
Okay. I sure can. We talked about men being a unique population in themselves, in that we also talked about the cowboy or the Montana reason for accessing or not accessing healthcare. And in that population, we also brought up the idea of increased die by suicide rate of our state, and also that social influence to be tough and not maybe access healthcare. I also thought that maybe women had more experience in general as a population, taking their parents or taking their kids in for exams. And so that was a unique population, that social. And then secondly, economics are different than in the women, because maybe women make 71 cents on a dollar to the men.
Yeah. Yeah.
So then when we looked at the senior population, our group, it's a social and community, depending on where they're living, but housing comes in there, as well as, this is anecdotal information from our group, because none of us particularly have facts or anything to base the decisions on for where you're ranking these. I thought, and some of the others agreed, that the health and healthcare access for seniors becomes complex as in a general way, transportation to the doctor, understanding doctor said, following through on what they said. They're from a population age group that might say yes, 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 act and appear that they have understood, and in fact got home and mixed up their medications. Yep. So it's difficult maybe to assess their educational retention or understanding of what's been delivered for the healthcare compliance piece.
So interesting. Thank you. I think you're going to hear some echoes of that and some of the evidence I'll provide in the last session here. And then group 5, who is our person?
Yeah, I'll cover group 5 this
Hey,
time.
Terry.
Hi. We on seniors, we talked about economics and how, as you get later in life, availability or access to long-term care through your network or through insurance, or even places that can offer long-term care, are limited, especially in Montana in the rural areas, nursing homes and assisted living facilities. And a lot of people just can't afford that. So it affects their access to care there. And also the specialty services, our infrastructure is limited. You have to drive long distances in the rural communities to get specialty services, which will also people that need it probably aren't getting it because they don't want to drive 2 or 3 hours, or they don't have time because their family has to work. And with men, we did discuss the suicide rate in Montana and the idea of the breadwinner and the cowboy mentality, a little bit about that. And I discussed the prioritizing healthcare and assessing risk to health. That's the risk assessment is just generally, it's always been like that since the beginning of time, I guess. With men, they assess risk differently, but the prioritizing health concerns, they might prioritize going to work over taking a day off, sick day, or because they have the flu. And we've seen that because of the traditional roles of that we have in the culture in Montana, in much of Montana. We still have the traditional, the father or the husband as the breadwinner. That's it.
Thanks, Terry. I think you bring up such important points having to do with self-perception and identity, and how those differ for males and females, and even in mainstream American culture. And the bleed over into health-seeking behavior is, absolutely there. So as you say, we in medical anthropology work on this all the time. This is really our bread and butter, about how identity is defined in different groups of people, and then how definitions of identity bleed over into health-seeking behavior, just like what you've described for rural frontier communities and maleness and how males are supposed to behave and the like. So those are really front and center for a lot of studies in the social determinants realm. A little bit down the path in the social and cultural kind of bucket of determinants, but definitely out there and absolutely fascinating studies. I'm going to switch the screen back over here to my slides again, and we'll move into the fourth session. This is to do with facility-based and upstream interventions. And I wanted to start by giving you all some examples of where facilities or hospitals or other entities within health systems are already working to address the social determinants of health in their communities. And you can see in the bar chart on the left that of the types of initiatives that are being pursued, community health education is pretty dominant. But it's followed not far behind by nutrition programs and health fairs, linguistic translation services being provided by community members to clinical settings or vice versa, and then other bits and pieces toward the end. Using the 2017 data that were pulled together by the American Hospital Association, we see that fully 91% have one or more collaborations with community organizations, community-based organizations like CBOs or private citizen groups. And so I just wanted to ask you to leave your mics on. We don't have to go into breakout rooms or anything, but I was wondering if anybody wanted to volunteer an example of a hospital or clinic-community collaboration or joint program that exists in your community. Are you guys already seeing a lot of this kind of thing happening where you are practicing?
This is Janet from Albuquerque, New Mexico, and I would say yes, there definitely are probably our largest locally based healthcare system has a very active foundation that has been working in multiple areas. You mentioned certainly the falls prevention, which I work with. Yes, they've interacted there. Food security issues. In fact, that particular hospital, at least pre-COVID, was hosting a local farmers market in their parking lot.
Is that right? Wow. Okay.
So there are definitely clear identifications of that, benefit.
Yeah. Anybody working in a community where they're not seeing anything like this at all?
So I actually live in southwestern Utah, and Utah has a very big hospital conglomeration that kind of has taken over the medical care in Utah. And we are kind of half and half. It depends on the situation. They do some food insecurity stuff like that, but I'm a prevention specialist, and part of my job is like tobacco prevention and stuff like, and they will have nothing to do with the community on tobacco prevention. So it's mixed depending on what project you're working on.
Interesting. Anybody else want to chime in before we move on? Well, I mean, at a minimum, it's good information to think about and mull over and maybe keep a working list at your office of those kinds of collaborators in your community, because the identification of stakeholders is one of the first things that you would want to engage in if you were to start pursuing initiatives that are informed by the social determinants framework. Just because there is oftentimes funding available for joint programs with clinical or settings of different kinds, hospitals or what have you. So this slide shows if you find yourself in a position where a local clinic or hospital health system wants to move forward and working together with you, these are some of the steps that can be taken. And I think somebody asked in the chat, I'm not sure if everybody saw this, but we do disseminate my slides. So these are available to you if you want to review any of the things that I've gone over later. So I won't walk you through these 6 steps, but they're pretty straightforward and in alignment with what I've discussed before or alluded to in other trainings that we do here through the training center. I've got a program planning and evaluation one coming up in the latter part of the month, and that certainly is going to hit on, number 3 and number 6. So now I wanted to end by talking about a couple more of the studies that exist that help demonstrate 2 things. One is the kinds of interventions we see within the healthcare system that are predicated on the social determinants of health framework, and then some upstream ones. So for within the healthcare system, there are 3, I think, that I chose that I wanted to show. One is the anticipatory care model. This is a really actually quite resource or time intensive approach that's been embraced by some practices in the UK, where they have retooled their understanding and language, the very language that they use to talk about their patients as, quotes, co-producers of health. They increase the time the clinicians spend with every patient. There's intense follow-up and long-term relationship building between provider and client or co-producer, and some staff expansion to provide comprehensive care. The results of this intervention in comparison with other settings where they didn't take this approach were lowered blood pressure among hypertensive patients, lowered smoking rates, and overall lowered mortality in comparison with those control groups. In New York, Tennessee, and Colorado, a program rolled out, which was called the Nurse Family Partnership Program. And that was focused on low-income adolescent and unmarried pregnant women. There were home visits that were the main approach, and those focused on reducing risky behavior and increasing prenatal care. And those visits continued after birth and provided support to generate or help people engage in economic self-sufficiency related behaviors, help them seek and obtain child care, and help them engage in future planning, as well as giving support to other caregivers other than the mom herself or parent, like support to grandparents. The results of this intervention were improved health-related behaviors during pregnancy, lower rates of pregnancy-induced hypertension, reduced rates of child abuse, longer interbirth intervals, and longer relationships with partners, and lower reliance on welfare and food stamps. They also did a cost-benefit analysis in this study and showed that there was a return of fully $17,000 for every family assisted by the program, as measured by reductions associated with it in crime, substance abuse, child abuse, and neglect, and also domestic violence. Talk about wraparound care, right? The last one is what was called the medical legal partnership model that rolled out at Boston Medical Center. Here, and this goes back to what I began talking about a couple hours ago, where the social determinants of health approach encourages public health practitioners to engage with stakeholders that you might not have engaged with before, in this instance with lawyers. So they developed a program at Boston Medical Center where they integrated on-site lawyers into the specialist network for primary care referrals from a pediatrician's practice. The premise was that low and moderate income families often face serious legal challenges that affect their ability to effectively interface with the healthcare system. And obviously that will adversely affect quality of life and ability to manage chronic illness. So they, those attorneys help them with issues having to do with housing, immigration, or disability. And also they did some support as well to income, insurance, or subscription models of care or payment, and access to just basic education, basic literacy, basic education. And unlike the other interventions I'm showing you today, this one is not rigorously evaluated yet, but they, the analyses that have been done say that it shows a lot of promise for improving care and the management of disease. And in my estimation, this is a really innovative approach. I think it's a wonderful demonstration for wraparound care that is truly multi-pronged and is truly innovative and creative. And obviously somebody was thinking way outside the box here. And I think that this is a great example of that kind of innovation that I think the social determinants of health approach unleashes in people who embrace it. In terms of upstream evaluation, so now moving away from the clinical setting or the facility setting, there was a program called Moving to Opportunity rolled out in New York, California, Massachusetts, Illinois, and Maryland. This was a fair housing demonstration project for low-income, mostly minority residents. They were randomly selected from high poverty neighborhoods, and they were helped to move to less poor neighborhoods. And then people who either moved or didn't move were randomized into the intervention and control, and they compared mental health of those who did and did not move. And the results of this intervention were that those who had moved had better overall health, less substance abuse, less of violence, and higher rates of employment / less reliance on welfare programs. So a lot of programs that you see that are upstream like this have a similar approach, but they include other elements that I've alluded to so far, like improved traffic, improved landscaping and lighting in neighborhoods around housing developments or what have you, strengthening of windows, things you might not think of as maybe kind of part of the bread and butter of a typical public health practitioner, but shown to be highly effective and efficacious on moving the dial on health outcomes. And then other interventions, and now I'm thinking internationally as well, have demonstrated results of programs like neighborhood improvement programs like this, including higher levels of trust, and some behavioral health outcomes, which are really positive, higher levels of optimism and higher levels of future thinking, and significant reductions in anxiety and depression. There was another that I wanted to describe to you called the Great Smoky Mountain Study / intervention. This was a sort of a natural experiment. It was measuring the impact of income supplementation on levels of mental health for children. They enrolled children 9 to 13 years old in North Carolina. They oversampled Native or American Indian people in that vicinity. What they did was there was a casino with a built-in sort of community surrounding it, and study participants received additional income as well as trust fund income from the casino's activities and profits. That averaged about $6,000 a year per household by the end of the study. There were also lots of new job opportunities available to people in this vicinity because of the casino and associated businesses. So the results of this intervention, which I put in quotation marks because it's just really a natural experiment. But children in the families with the supplemental income had declining rates of deviant and aggressive behavior. By year 4 of collecting data from these households, their levels of psychiatric symptoms or their level of psych symptoms was comparable to those of children who were never poor in the first place. And other interventions like this have shown similar effects where job support alone, like employment-based anti-poverty programs, are shown to have a positive impact on children's school achievement, motivation, and social behavior. And that's particularly true for boys and boys aged 6 to 16. And if folks in this group have sons who are in that age group, we know how vulnerable they can be. Just one last study. This is an early childhood academic enrichment study. It's called the Perry Preschool Program, where 123 African-American children were randomly assigned to intervention and control groups. In the intervention group, the teacher held one extra daily class with students, and they made a weekly home visit. And the results showed that at age 40, the intervention group had higher graduation rates, higher socioeconomic status, lower lifetime rates of crime and welfare dependence. And though health outcomes were not specifically evaluated, the socioeconomic status finding is significant because of the ripple effect of socioeconomic status on health outcomes. So we can presume that there's some connection there with health outcomes, even though that wasn't specifically measured in this particular study. But other very similar interventions in other places followed children through older ages and found that the intervention groups had lower rates of some behavioral health outcomes, but also lower rates of crime, and had higher educational attainment and health insurance rates. So these studies I pulled from the Healthy People 2020 site. So if you're interested in learning more about them, you can find them there. And my last slide has just to do with ways forward. Again, I bring us back to what people are recommending for initiating programs that integrate a social determinants of health approach. First of all, consider the available literature on interventions that are effective, kind of like I've done in here today. Most of these are very thoughtfully designed, in my estimation, in the way that they are really tailored to the local population that they're aimed toward. And you're going to have to tailor your interventions as well to your community, and should be doing so. And kudos to you in advance for doing so, because there really aren't boilerplate, fine-tuning features that are going to apply in every single community. So it really calls us as designers of interventions to know and understand our social, cultural, and economic landscapes, and those in the target communities. So also understand that non-medical interventions are likely to be differentially effective for different health indicators. So for instance, improvements in education might have a big impact on health outcomes where knowledge is important. For instance, management of fertility, like if you can't read or if you have poor health literacy, it can be difficult to know how to use birth control effectively if you don't have a coach right there walking you through it, and you're reliant completely on your own literacy level. Alternatively, improvements in material resources are likely to have a big impact on prevention or management of some illnesses, but not so much on others. Might be better for management of physical disability, for instance. Okay, last, just a reminder and a plug for Healthy People 2020 and newly Healthy People 2030 to frame your interventions. And like I showed you in the leading health indicators, it's really laid out for you, like the creative, imaginative, innovative part is yours to do in program creation. But then when you want to measure the work that you've done, when you want to compare the data that you're collecting with other interventions like it in other localities, that kind of information is all provided for you using the leading health indicators on the Healthy People 2020 or 2030 websites. And so that makes that part of it a lot easier. And then I've just hyperlinked where those objectives, again, can be found. Again, back to Healthy People 2020, but the LHIs are also present for 2030. Well, I'm going to end there. We are going to ask you to fill out the evaluation for today's webinar, and just remind you that for people who need the certification through continuing ed for nurses, that we won't know where to send it if you don't do our evaluation. So please avail yourself of the opportunity to do the evaluation. It's in the link, and I think Alexis will tell you a little bit more about that.
Yeah, I just posted it in the chat. So if you could please take the next couple of minutes to complete it. It's super short and sweet, but it really helps us to tailor these trainings to your needs individually. So appreciate it in advance. And Emily wanted me to remind everyone that to get nursing credits, so if you are interested in getting nursing credits for this training, you have to take the evaluation and then contact Emily for your certificate. So I think that's all that I have in terms of reminders. Just wanted to say thank you so much for being here on behalf of the Montana Public Health Training Center. We'd love to see you again, so please check out our website for future upcoming trainings.
Thank you also from me, and thank you to Emily and Alexis for your support. I always appreciate that. And also thank you everybody for participating so collegially in the breakout rooms and sharing the reflections that you shared. That makes it a million times better and also helps me tailor for the next time we get to offer this webinar. So again, thanks so much, and I hope you guys have a good rest of your day.
Take care, everybody.